Okay. Yeah, of course.
This is Joe. Wow, they're getting the technical details sorted. Joe Pekacek, one of the NIH visiting fellows. We're very fortunate in our program to often have one of the fellows from the NIH join us for a couple months at a time. And due to some Jeopardy coverage, Joe, whom most of the audience will recall from his superb presentations here last year, is joining us again for an additional week and a half or so back at Hopkins. So Joe, great to have you back with us, and thanks again for putting together the presentation for this morning.
Happy to be back. No worries. I just could not keep away. Apologies for any roughness around the edges, but I think we will have a nice presentation, especially for early in the year, which will hopefully be up in a minute. Why does it make me sign it again? There we go. Apologies, one moment, and we will be good to go. All right, can we all see the presentation?
Looks great,
Excellent.
Joe.
All right, so we won't perseverate on going through these badly warped with my background opening slides. So we see my title here, not nearly as flashy as iHeart ID, but we'll jump right in. So for our case today, we have a 67-year-old woman from Virginia. She's presenting with 4 days of fevers, chills, and fatigue. She also noted a headache that started about 3 days ago. It started pretty mild, but continued to bother her and was very persistent, couldn't shake it with acetaminophen, which normally would do it for her. And really, she's coming into the hospital now because her family's concerned with this fatigue that's progressed throughout these 4 days and insisted that she present to the hospital, which is where we are now seeing her. Still has this mild frontal headache, no photophobia, no phonophobia, no waking her up at night, no real red flag symptoms with it, but still febrile on presentation of 38.6 as we see here. In chatting with her more, she does note attending a family picnic about a week ago, so maybe about 5 days prior to developing these symptoms, but no other family members had any symptoms in particular. On top of this, as you can see here, some additional kind of negative review of systems. In terms of her history, she does have a history of rheumatoid arthritis, as we mentioned, for which she's now controlled on her etanercept, as we see here. Also hypertension, for which she takes amlodipine. So a surgical history of a cholecystectomy in the past, no immune deficiencies, frequent fevers, anything particularly jumping out in her family history, really no history of rheumatological disorders either. Lives in Virginia, as I had mentioned, now retired and had the family picnic that we mentioned a moment ago. No allergies, and we already talked about her meds. So on exam, she's febrile, as I had mentioned, and tachycardic with a heart rate at 107, and maybe borderline tachypnic, as we see here as well, but saturating reasonably well on room air at this time with an appropriate blood pressure. She does appear uncomfortable, though not overtly toxic, and certainly resting in bed otherwise. Going through notable things on her exam here, the tachycardia we mentioned. She did have some bibasilar crackles on her respiratory exam on presentation, as well as some noted splenomegaly. Otherwise, she did have a macular papular rash on the gluteus and posterior thighs that she herself had not noted, partly because there was no tenderness, pain, pruritus, really any sensory disturbances associated with this rash at all. So she couldn't really tell us when it had developed because she had not noticed it. In terms of some labs for you, you can see here a bit of a pancytopenias, in fact, with a pretty well-preserved, relatively well-preserved neutrophil count. But you can see here our white count of 2.85, platelets at 114, low hemoglobin as well. The differential there off to the left of the CBC. In terms of our BMP, nothing too much that I'll perseverate on there. You can see it there in front of you. On her LFTs, we do see these elevated AST and ALT. She did come back with a negative HIV screen, a normal smear with her blood. And otherwise, in terms of labs, I'll mention the negative respiratory pathogen panel, pretty markedly elevated ferritin, a bit over 15,000, elevated triglycerides as well. So overnight, she becomes increasingly tachypnic, increasingly somnolent, and she actually ended up being intubated really for respiratory protection just based on her declining mental status at that time. Ventilator settings, 40% P5, and fevers continue perhaps now higher than when we first met her at 39 Celsius. So not going too far forward, perfect. So we have our 67-year-old lady with RA on DMARDs presenting with fevers, pancytopenia, hepatocellular injury, and respiratory failure. And here I will pause so that we can discuss the differential. You can stop sharing. No, perfect.
Thank you very much, Joe, for sharing. Folks new to this conference will know that we rarely have volunteers to discuss, but I did just get a Zoom chat request from Dr. Robin Avery to discuss the case. So Dr. Avery, I will turn it over to you and thank you for volunteering to share your thoughts about this case.
Thank you, Michael, and thank you, Joe. I apologize that I'm not there in the cater room with you, but can you hear me?
We can hear you fine, Robin. Thank you.
Excellent. So just to summarize briefly, this is a woman in her 60s with rheumatoid arthritis on etanercept. She lives in Virginia. She comes in with 4 days of fevers, chills, fatigue, headache for 3 days. There's a talk of a picnic that she went to. When she comes in, she's got a fever of 38.6. She's tachycardic. She has a maculopapular rash over her gluteus and thighs. And her labs are notable for pancytopenia with a neutrophil count of about 1,000, platelets under 14,000, and a quite elevated ferritin, 15,000. Sounds like she then develops a rapidly progressive course that includes respiratory failure and multi-system involvement. So I think there's several different ways to approach this. First of all, this is clearly somebody whose immune system is not normal. Although perhaps we think of etanercept as maybe not quite so immunosuppressive as drugs like infliximab and so forth, for which we know of associations with tuberculosis, histoplasmosis risk, and things like that. Still, etanercept is definitely, as a modifying agent for an autoimmune disease. It does predispose the patient to some worse manifestations of some perhaps common illnesses. In thinking about working up this fever, we think about things like the tempo of onset. This is relatively recent and rather acute presentation, although we might think of diseases like primary CMV or EBV infection, which can have marked manifestations when they occur later in life. If you happen to be one of those people that escape these diseases in childhood and then you get primary infection later on, sometimes grandkids or whatever, you can get unusual manifestations, more commonly rather insidious in onset. They can certainly cause fever, pancytopenia, and fatigue, but this rapid progression would be unusual. I think while we're talking about, we should include, given the superb previous presentation, BZV here, which certainly can cause multi-system illness and altered mental status, HSV as well, encephalitis and so forth. But again, these would be rather unusual manifestations. I should also probably add human herpes virus 6, which again, if this person has to be one of the 5% of people that didn't get it before age 2, she might acquire it from a grandchild. And of course, in this summertime, we think about things like enterovirus, especially various types of Coxsackie, which can certainly cause in immunocompromised hosts, sometimes actually a quite fulminant multisystem illness with respiratory failure and cardiac dysfunction as well. We have seen myocarditis from Coxsackie as well in some of these folks. So that has to be in the differential. However, I want to focus on another really important feature here, which is the high ferritin. And my guess is that this ferritin probably explodes and goes even higher after that, that the 15,000 is just the start. That focuses our concern on whether this could be HLH, and specifically HLH triggered by an infectious process. So around in this geographic region, we have several more common triggers of HLH. One of our main ones, especially in summer months, which I assume this probably was given the picnic, is ehrlichiosis, which of itself can certainly cause cytopenias. And so I have to say Ehrlichia is up there with the presenting symptoms of the headaches, systemic symptoms, and so forth. Along with that, we also, not in the bacterial category, but another pretty common trigger here of HLH is histoplasmosis. And she could have disseminated histo, and certainly that's associated with more infliximab, but really all of the biologics in that, the anti-TNF and similar categories. But again, this is a pretty fulminant presentation. We don't have a strong history of any, well, I don't know actually whether she lived on a farm or raised chickens or anything of that nature, but we'll put histo on the list, but I'm not thinking that it's top of the list at this point. We also do see EBV as a trigger of HLH at times, but again, that would be a little bit less common in somebody who presumably probably was EBV seropositive for a long time. Getting back to Ehrlichia, we need to include other tick-borne illnesses. So we should include anaplasmosis, which is a less common trigger of HLH than Ehrlichia, but does occur. We'd also want to include Rocky Mountain spotted fever with the rash, as well as the other rickettsiosis. Could this be babesiosis? I think this would be a pretty, sorry, I guess we need another category for that rather than the bacteria. Just thinking about tick-borne infections, it would be rather unusual presentation for babesiosis, and we might expect, rather than leukopenia and thrombocytopenia, maybe more anemia and things visible on blood smear, et cetera, but we can leave that in there. I would add toxoplasmosis to the parasite list, and I would add listeria to the bacteria list. Certainly foodborne diseases have to be a possibility given this picnic. And again, listeria CNS manifestations can be unusual. You can have brainstem encephalitis, et cetera, as well as the classic meningitis presentation. Could this be an unusual presentation of other foodborne bacteria such as Salmonella or Campylobacter? I would have to say that would be pretty uncommon. So there's probably actually a lot of other, let's put disseminated mycobacterial infection as well, with the pancytopenia, fevers, et cetera. Although I think, again, this is a rather acute presentation. So if I had to really go for one of these, I would have to say HLH triggered by ehrlichiosis in an immunocompromised patient. There's probably lots more, but I'll go ahead and open it up.
Robin, thank you. Superb differential diagnosis as always, and we'll now solicit additional suggestions from the audience. Please post those in the chat or unmute, and Dr. Cheetah will turn it again over to you.
Any additional comments? It's always hard to think of things that Robin has not thought of. Thank you, Matthew's adding LCMV. Great. And Joe, I'm actually, we're not recording this, so like, is this a current case?
No, we're recording.
Okay,
We're
never
recording.
mind.
Thank you, Dr. Cheetah.
And then Bill is just adding West Nile and other arboviruses, so I'll put in that specifically as arbovirus NOS. And then I will just add monkeypox, the rash, and some systemic symptoms, and we have seen some more systemic symptoms with that infection as well. Any other additions? All right, so in the interest of time, I am going to MISA, so I'm going to have SARS-CoV-2, and then we'll ask Joe, is the answer on the board?
In addition to being honored that Dr. Avery would volunteer to do a case of mine, I'll also say yes, the answer is on the board.
Great, so while Michael is furiously making the poll, I will pull our group here, but there's a lot of options. So in the interest of time, I'm actually probably not going to go through everything, and I'm going to focus on a couple of diagnoses. So folks for Ehrlichia, that's pretty much everybody. So we have more people who've come to the room since our last case. So I'm going to say there are 400 votes for Ehrlichia. And the poll has been launched for the group.
You know, ATIC was like that.
But we are all in bubbles.
So let's wait here for the online voting to take place. I apologize, Dr. Werble, I missed your SARS-CoV-2 edition, so that one is not included, but I think others are captured on the list. Robin's great thoughts and the additions. All right, a few final votes are coming in here. We will end here momentarily. All right, and so folks should see it now. So you can see the vast majority of folks in terms of process think that this is HLH. A few votes for infection without HLH, and in terms of pathogen, sounds like as with the in-person audience, Ehrlichia got lots of votes, with one each for EBV enterovirus and Rocky Mountain spotted fever. And then in the second grouping, another rickettsial illness and West Nile virus led the way with a few votes for Babesia and then one for Listeria, Salmonella, monkeypox. So Joe, great case. Thanks again for putting it together on such short notice, and look forward to your discussion here.
No worries. So yes, I did not hit you guys with prototheca this time like my last presentation. And I think everyone hit this nail pretty well on the head. So Hugh and Groom were both consulted given concern for HLH-MAS. We will briefly discuss that nomenclature in a moment and why it's woefully inadequate. But Heme was initially planning to perform a bone marrow biopsy, but ended up deferring because the diagnosis of HLH was made. And suspect we're mostly familiar with the H-score, but if not, a clinical tool that takes into account your number of cytopenias, your ALT, your triglyceride level, your fevers and how high they are, your ferritin, and then calculates kind of a probability of HLH. And as you can see here, she was quite off the charts. So to give it away, here's our friend, our amblyoma with the eponymous lone star, and of course the serrated carapace at the edges there. But she was initially started on cefepime, metronidazole, vanc, and doxy as kind of a broad coverage as things were being figured out and cultures were pending. But sure enough, she was started on steroids for HLH in consideration of anakinra. EBV, CMV, HSV PCRs were all sent and were negative, and blood cultures remained negative. And then it was kind of a situation where we had our differential being worked up, came home the next day, and she was kind of whisked off because at that point, I think Heme had been concerned about the progression of her HLH at that point and how ill she was, and further discussions with family who decided to focus on comfort at that time. And she was actually discharged to hospice. And then in the interim, her Ehrlichia Chefiensis PCR didn't even turn positive. But that's not the end of the story, which we'll get to momentarily as I fly through a discussion in 5 minutes. So terminology is problematic, as I alluded to. We've got familial, sporadic, and MAS, or macrophage activation syndrome. We'll often use these terminologies to say genetic cause versus infectious cause versus rheumatologic cause. But in reality, there's a wide spectrum of overlap where, perhaps we don't have a specific mutation that will give you predictable HLH in childhood, but likely folks who do develop things like what we call a sporadic HLH have some kind of underlying genetic predisposition to have this sort of inappropriate response to infection that's so self-damaging. So really, this is a blurred kind of a fake sort of line that we've drawn in between these three different entities that are really all kind of within the same dome. So generally, we'll talk about immunology briefly because I think it's fun. We essentially have defects in NK cells and cytotoxic T cells' ability to perform cytolysis, and we'll talk in a moment where Ehrlichia comes in play specifically, but ends up leading to unchecked a cytolytic T cell kind of expansion. From there, you get further inflammation being promoted by continued unchecked antigen presenting cell activation. So you kind of have multiple branches of this system that are sort of getting overly out of control, overly activated. We ended up getting stimulation of tissue macrophages leading to cytokine storm as Tregs are overwhelmed and trying to tamp down this now runaway inflammatory response. There are some infections that directly affect proteins within the pathway. So for example, EBV is known to interact directly with SH2D1A, which actually is kind of downstream of some, or upstream rather, of some of the responses for macrophages to start to develop cytokine storms and kind of out of control cytokine production. And likely, as I alluded to, a milieu of factors really lead to HLH risk in a specific patient, including genetic exposure to infections and even medications that they're on. I won't perseverate on this slide for time, but I think in addition to pointing out that it's probably not totally accurate to say Tregs are a pathogenic response, like trying to make the point about inflammation and fighting infection here, but clearly that's also has its green aspects, its protective aspects. But the main thing to point out here is we're already showing that this is from an article talking about Ehrlichia's interactions with the immune system. We can see that we do particularly see this heavy clonality of cytotoxic T cells and them playing a role in what we would already call kind of the elevated liver enzymes that we see in Ehrlichia, and it's sort of the same mechanism that we just discussed as playing a role in HLH. So Ehrlichia can stimulate these sort of overall inflammatory responses through PAMPs, our pathogen kind of recognition systems, and MyD88, of course, of multiple immune pathways fame, and particularly NRLP3, one particular inflammasome that's also known for being quite overly active in HLH, also plays a role in clearing intracellular bacteria, of which, of course, Ehrlichia would be one. And it's actually thought to play a more pathogenic role rather than protective role in Ehrlichia, as when you actually knock out NRLP3 in mice, they actually end up surviving ehrlichiosis sort of 100% of the time, as opposed to their wild type mice who, without intervention, have quite high mortality rates. Ehrlichia can use autophagy to its advantage as well. So actually, in addition to promoting autophagosome formation, it kind of is then able to use those as ways to protect itself off from the rest of the intracellular cytoplasm, and actually directly inhibits autophagy flux, which is to say the ability for those autophagosomes to actually digest via interactions directly with MyD88. There for now. So talking about Ehrlichia and HLH in general, when those two come together, as Dr. Avery mentioned, a very well-known kind of association with the two. Generally, HLH, just all causes, and we're talking sporadic, familial, even rheumatological related to MAS, has a rather high mortality rate. And really, I think it's important to stress the importance of not just treating infection if infection is present, but also tamping down that immune system. So the steroids and the thought to anakinra that Hemonk had with the patient at the start of this case, as we had discussed. Relatively lower mortality, perhaps if infection driven predominantly, because treat that. Prompt initiation of doxycycline decreases mortality when it is from Ehrlichia, as we would expect, true of many of our tick-borne illnesses. And really, on review of available case series, mortality from Ehrlichia-induced HLH treatment with prompt treatment was 0 to 10%, and those mortalities were in really severely immunodeficient patients. Interestingly, none of these patients were known to have a familial predisposition to HLH, but as we discussed before, genetic causes almost certainly play a role as well. So biologics have been proposed to use as therapies of HLH as well, as we kind of touched on a moment ago. But the question I had here was, this patient's on etanercept to begin with. Is that something that could have been protective or actually harmful in developing the HLH itself on top of ehrlichiosis infection? So of course, thoughts about IL-1 blockers like anakinra, IL-6 inhibitors, the latter of which have really come under less and less favor of late in treatment of HLH. But we also know immunosuppression through rheumatological disease and otherwise may contribute to development of infections leading to HLH. And a review of patients with autoimmune syndromes actually found that folks on TNF alpha inhibitors, folks who had autoimmune syndromes who then developed HLH, most commonly they were on a TNF alpha inhibitor as the biologic they were on preceding development of the syndrome. And interestingly, about 70% of folks receiving DMARDs prior to HLH had some infection deemed as the cause. So really giving credence to this idea that, well, first of all, we have a multifactorial kind of picture of medications, autoimmune diseases, and infections leading to this risk for HLH and genetics. But also, your DMARDs, your immune suppression may also increase your risk of having an infection that would then drive your HLH. Most common infections in this population were tuberculosis and CMV, and particularly with the TNF alpha inhibition, tuberculosis perhaps isn't a terrible shock that that would be one of the drivers here. So briefly, to give some closure to the case, I had an interesting conversation with the hospice folks trying to make a case that maybe doxycycline was a palliative medication to help maybe make her more clear and enjoy time with her family. And encourage continuing this even more when her PCR testing came back positive, and they were pretty much game to do that. And actually, she then effervesced, became more alert and awake, and her CMO status ended up being revoked. And the way it was worded to me was that she walked out of hospice, which I don't know if that was literally true, but she left hospice and eventually returned to her prior baseline. So at least a happy ending for her there. I do want to make the brief point of keeping in mind then from a clinical treatment perspective that folks with HLH from infections, if you treat them, immune suppress and knock down the out of control inflammatory response, they do tend to get better and have a high chance of that. So, giving a chance before turning away and kind of going the CMO route, and the importance of that immune modulatory effects as well. Here's the picture of the cat, that's okay. And my references as well, you'll have to trust me. And that is what I got.
Ivy saves the day.
Joe, spectacular case presentation and discussion. Again, especially given the very short notice in putting it together. So thank you for that. Welcome back. And thanks again for doing that. And thanks to Robin for your superb discussion, as well as yours, Ashwin, and Seth, your great case presentation, Natasha for holding down the fort in the room, and to everyone for joining. So thanks very much, everybody. Have a great day. And to all the applicants, we look forward to seeing you in your conversations with faculty throughout the day. Take care, everyone.